and I will turn it over to him.
Well, welcome. It's good to see everyone this morning. Thank you for joining us. We're going to be talking about pain management, which is a key topic in palliative care and hospice. And specifically, we'll be focusing on an individualized person-centered approach, including patients with impaired communication, as is often the case in the hospital setting. We'll be identifying non-opioid, but particularly focusing on opioid-based approaches to pain management in palliative care patients, informing opioid dose conversions and identifying common options for treating refractory pain. This is an introductory lecture. There are many lectures during the year that will cover more specific topics, and I'll mention those as we go along. I'd like to start with two cases. One is a man with COPD, lung cancer, and chronic low back pain who has been on long-acting morphine, 30 milligrams BID, and PRN oxycodone with acetaminophen, admitted with pneumonia, sepsis, and severe shortness of breath, fever, cough. As is the usual practice, opioids were held on admission because he was encephalopathic because of his severe illness, and of course his back pain is worsening since then. Another patient is a lady admitted to the inpatient rehab unit following an MVA and multiple surgeries, and pain is interfering with her ability to do rehab. So hospitalized patients often experience pain due to a lot of different reasons. So medical illnesses can be painful, infections, inflammation. Oftentimes the pain medications are held because someone is NPO for a procedure, or there may be trauma or post-op issues, pre-existing chronic pain worsened by lying in bed. I can't tell you how many times I've heard that about back pain. And this causes increased stress, decreased appetite, decreased function, anxiety, depression, fear, PTSD, sleep deprivation, risk for chronic pain if someone has severe acute pain, prolonged ventilator if someone's pain is not treated adequately, and increased mortality. Pain is a more terrible lord of mankind than even death itself. How many times have you heard people say, I'd rather die than live like this, or I'd rather be dead than be in so much pain? And sometimes pain can make people, frankly, almost suicidal. So it's important to take time for a comprehensive pain history, as Joel mentioned last week, the importance of listening to the patient, believing them when if they say it's pain, to them it's pain. And of course, the usual pain history and characteristics, and recognize that everybody's different. And there are a lot of different things that affect pain. So emotions, age, gender, race, culture, socioeconomic status, psychosocial supports. It's important to assess the diagnoses, the causes, and the comorbidities, review current and past treatments and their effectiveness, and be alert to coexisting psychiatric conditions, prior trauma or abuse, or substance abuse. In palliative medicine and hospice, the concept of total pain is something that is important to keep in mind when we're taking a holistic look at the patient. We want to focus on not just the physical side, but the psychosocial, emotional, and spiritual aspects of pain. Pain is kind of like the volume knob on the stereo. Different things can turn it up and other things can turn it down. So pain is worsened by poor sleep, fatigue, fear, anxiety, denial, anger, depression, loneliness, financial stressors, loss of faith or meaning, spiritual distress. And as pain gets worse, it can worsen function. It can worsen relationships, mood, sleep, and ultimately quality of life and enjoyment of life. Now, in patients who are nonverbal or who are obtunded, it's hard to know if they're in pain because they can't tell us that they're in pain. And they may be on a ventilator, they may be on sedative medications, or just be so ill that they can't communicate well. And don't just assume that if they're not moving and they look calm, that they're not in pain. Or on the other hand, don't assume that if they're anxious or restless, that automatically means pain. A lot of times family or staff who maybe know the patient a little bit better than we do can give us a better idea of whether they think the patient's in pain or suffering. In acute pain, the vital signs, the heart rate, respiratory rate, and blood pressure may be elevated, but not necessarily. That's not always the case. And there are some objective tools that look at behavioral signs of pain, and oftentimes these are embedded in the EHR, such as the Behavioral Pain Score, BPS, which is a score of 0 to 8. The CPOT, Critical Care Pain Observation Tool, is 0 to 12. But one that I particularly like is the Pain AD score because it's 0 to 10, like we're used to. It's for nonverbal patients. It was originally developed in patients with dementia, but it can be used in any patient who's nonverbal because it looks at 5 different areas, and these are quantifiable and you can follow them over time. So each area is scored 0 to 2, normal to severe, and it looks at breathing, negative vocalization, facial expression, body language, and consolability. And so you can look at these and assign a number, 0 to 10, and then you can follow that patient and see if the numbers are getting better or worse. And this is actually embedded in our EHR in Cerner at Borges Hospital, which is now called Beacon Hospital, by the way, Beacon Kalamazoo. We've been bought by Beacon. I'd like to talk about pain management now, and sometimes this can be a thorny subject because there's so much fear about opioids among not only the general public but the medical professions. And in 2016, when the CDC tightened their opioid prescribing guidelines, all of a sudden there were many primary care physicians who just said, "Well, you know what? I'm just not going to prescribe any opioids." Or I'm just going to, only go up to a 90 MMEs. I'm not going to go beyond that, which unfortunately caused problems for people who were on opioids for years and it was helping them function, and maybe they were on a higher dose. But when you're individualizing pain management, you need to establish realistic and individual goals, ultimately focusing on improving pain and quality of life and function. The idea, if there is chronic pain, is coping rather than cure. They're never going to get that pain down to a 0. But what would be a livable level? What would allow them to do the things they want to do and be reasonably comfortable? And also, of course, consider the cause of the pain, the type of pain, the severity, the duration and timing, and treat the whole person, including their underlying depression and anxiety, which can make pain worse. Discuss the risks and benefits of opioids before starting, and follow up closely and at regular intervals to assess safety, efficacy. In other words, are they experiencing any troubling side effects? And are the medicines actually helping improve their pain or not? And consider an empiric trial. And it's also reasonable to first consider non-opioid ways to treat pain, as Joel mentioned last week. And I won't go into detail on these, but just to mention, there's non-pharmacologic ways like physical activity, walking, staying active, psychosocial and spiritual. So being engaged socially, engaging in distraction techniques to help the brain focus on something other than just the pain. Environmental cues, better to be in a well-lit room with other people than tucked away in a bedroom or a hospital room with the curtains closed and the lights off and just ruminating on their pain. Procedural things like nerve blocks, surgery, radiation, these will be covered in later lectures. And then pharmacologic, like non-opioids, like acetaminophen, NSAIDs, if there are no contraindications, antidepressants, such as tricyclic antidepressants, SSRIs, SNRIs, gabapentinoids, steroids, topical analgesics, and alpha-2 blockers. And you saw a similar slide last week about the pain types, just to remind you the 3 basic types: peripheral or nociceptive, neuropathic, and central pain or non-nociceptive. So peripheral, usually due to inflammation or mechanical damage, often responds to NSAIDs or acetaminophen or procedures. Neuropathic, due to damaged nerves or inflamed nerves, responding to the oftentimes the TCAs and the gabapentinoids. And then central pain, which can often respond to TCAs and neuroactive compounds. With cancer patients, they can have a lot of different pain types, and so there are actually a lot of different medications that will help in the setting of cancer. So In general, starting with acetaminophen or NSAIDs is reasonable if the pain is mild to moderate. If it's more severe, then opioids may be used. Steroids with or without radiation are beneficial for brain and bone mets, lymphangitic carcinomatosis, SVC obstruction. And again, you might see a question on the boards about that would require you to know when are steroids appropriate in the setting of cancer. So these are all evidence-based treatments for pain in cancer patients. And then also adjunctive treatments like calcitonin, bisphosphonates, and of course having GI prophylaxis with those medications. Visceral pain, on the other hand, is more colicky, more like sharp and intermittent, like for instance, malignant bowel obstruction is treated specifically with opioids, anticholinergics, steroids, octreotide, haloperidol, and proton pump inhibitors. The steroids reduce bowel wall edema, and the octreotide reduces intraluminal secretions. The anticholinergics reduce some of the spasm, and the Haldol is a potent antiemetic, and then the PPIs reduce the stomach acid, of course. And then neuropathic pain in cancer. This may be due to chemotherapy side effects or due to actual nerve impingement. So anticonvulsants, like the gabapentinoids and TCAs, may also be helpful. SNRIs like duloxetine and venlafaxine, local anesthetics like lidocaine, capsaicin, and then tramadol, tapentadol, methadone, ketamine may be useful for neuropathic pain. So now let's bring out the big guns. Let's talk about opioids, everybody's favorite topic. When are opioids appropriate? Basically, when non-opioids fail to improve function and quality of life. And then in cancer pain, if it's moderate to severe, especially nearing end of life, there's in general in the medical community more latitude with giving opioids. There's less concern about addiction, although the issue of opioid use disorder or addiction is more, I mean, that can be found with anybody, even cancer patients or non-cancer patients. It's a lot of the risk factors for cancer involve smoking or alcohol, which are also associated with addictive tendencies. So even in patients who generally need opioids, we still have to be on the alert for patterns that might suggest overusage or over-reliance on the medications. And then for non-malignant pain, if it's moderate to severe and it's interfering with their function and quality of life, and you've tried non-opioids, then it may be reasonable to do a trial of opioids, especially if the benefits outweigh the risks. And obviously check the MAPS beforehand and do appropriate screening for opioid use disorder. I'd like to highlight the difference between short versus long-acting opioids. Short-acting opioids are really more for incident or breakthrough pain. They're not for pain that's continuous and ongoing unless they're opioid naive. Because if they're opioid naive, you're not going to want to start a long-acting opioid right away. You're going to want to try short-acting ones, initially PRN, and then possibly scheduled, and then see if they're needing enough, high enough dose, then it might be reasonable to add a long-acting opioid if the pain is likely to be going on for the next weeks to months or longer. Dosing schedule for short-acting is either PRN or scheduled, but for long-acting, it's only scheduled. There's no such thing as a PRN long-acting dose. It just, because it kicks in gradually and lasts longer, it's not really appropriate to dose at PRN. And then I've just given some examples there that you're all familiar with. I'll just focus on the long-acting ones. So basically for long-acting opioids, we have the long-acting morphine, fentanyl patch, oxycodone extended release, methadone, and also buprenorphine. It's helpful to know when you give a medication, how soon should you begin to see the effect, when should you see the peak effect, and then how long is the medication going to last? Because you don't want to dose at PRN with a range that's outside of its effectiveness. In other words, don't dose PRN morphine every 12 hours as needed because it's going to wear off long before the 12 hours is up. Most of the time for IV medications, they'll last 4 hours or less. For oral medications, they might last up to 6, maybe 8 hours, depending on renal function. And then transdermal fentanyl is basically 3 days. Usually it lasts 2 to 3 days. And when you give an IV medication, it should begin to take effect within 5 to 15 minutes. So if they are in agony, if there's a crisis and they just look miserable, after 15 minutes, you can redose them if it's IV. The exception being hydromorphone because it has a longer half-life. So that you really can't dose more often than every 1.5 to 2 hours. But fentanyl and morphine you can dose every 15 minutes if it's a crisis. For instance, someone coming off the ventilator for comfort care or someone in excruciating pain that you need to try to get under control really quickly. And then the PRN doses should be proportional to the total daily dose, about 10, no more than 25% of the total daily dose. Also related to pharmacology, the peak effect of IV medications is usually by 30 minutes, whereas orally it's by 90 minutes. And then the duration, obviously they have different durations. So keep that in mind. If you need to get somebody's pain under control now and they're in a lot of distress, give it IV to get started. And then you can use oral medications once the pain is more manageable. All right, so for achieving rapid control, bolus will always get the pain controlled faster. Titrate to effect. And then as you're evaluating how much they're using in a 24-hour period, you can determine how much to increase the dose if needed based on the severity of their pain, anywhere from 25 to 100%. But I wouldn't go above 100% increase in the next 24 hours. And there's really no ceiling dose unless they're developing excessive sedation or respiratory depression. And sedation is often seen first before the respiratory depression. So if they're starting to get a little spacey, a little bit foggy, then it's time to tweak the dose down a little. All right, now we'll talk about changing opioids or dose conversions. There are many reasons to change, including if they're just not tolerating one particular opioid, having adverse effects, or maybe it's not working like it should be, and you want to try a different opioid to see if they respond better. Or maybe they're developing kidney failure and you need to switch from morphine to fentanyl or something like that. Or they're having dysphagia and can't swallow pills. So you need to know what medications can be given either as liquid or crush the pills. And then also switching from IV to oral in preparation for hospital discharge. And also what's available at the pharmacy and how much does it cost. The process involves assessing the severity and the chronicity and what's been prescribed and how effective it's been, and then choosing the opioid, calculating and individualizing the dose, and monitoring the patient. This is the classic equianalgesic dosing table, and I rearranged it in order of potency. And this is the one that's been used on board exams and smartphone apps for years. There is a newer one that I'll reference in a minute, but just know that codeine is the weakest. Morphine and hydrocodone are equal potency. Oxycodone is 1.5 times as potent as morphine and hydrocodone. Hydromorphone is roughly 4 times as potent as morphine. And then fentanyl, of course, is a lot more potent. So this is the one that Dr. Lynn McPherson out of University of Maryland developed a number of years ago, updated based on evidence. So what we find here is that the conversion between IV and oral morphine basically is like 2.5 milligrams of oral is the same as 1 of IV. That's helpful to know because oral morphine elixir, also known as Roxanol, which is often used in hospice or comfort care settings, comes as prefilled syringes, 2.5 milligrams, 5 milligrams. So that's like 1 milligram of IV morphine or 2 milligrams of IV morphine. Also, the hydromorphone to morphine ratio here is a little bit different. They're saying it's orally 5 to 1, and IV it's 12.5 to 1. sometimes if you do a straight conversion, you end up overshooting and giving someone more than what they need. So I usually, to make the math easier, I just, for IV Dilaudid to oral morphine, I just do 1 to 10. That errs on the low side, and then you've got room with your PRN medications to make up the difference. So the easiest way is to just do the 1 to 10 for the for IV hydromorphone to oral morphine. Oxycodone, converting that to morphine equivalents, basically multiply by 1.5, is probably, they have a slightly different range there, but in my experience, it seems to work pretty well. And also note that there is a lot of individual variation based on opioid metabolism and tolerance. So you can have somebody, a young person who metabolizes opioids very rapidly, or you could have an older person who metabolizes them more slowly. So that's why I think it's better to err on the lower side when you're making your conversions, and also because of tolerance. So there is a concept called incomplete cross tolerance, where you, after you calculate your 24-hour morphine milligram equivalent or MME dose, and then convert to your new medication, then you can reduce it by at least 25%, just in case someone might be more responsive to a different opioid because of the way they metabolize that medication. And you can reduce it by as much as 50% if you need to. All right, so here's some specific examples. So morphine 2 milligrams IV is 5 milligrams orally, which is also the same as hydrocodone, 5 milligrams, or hydromorphone, 1.5 to 2 milligrams, orally, that is. Hydromorphone, 1 milligram IV is 3 to 4 milligrams orally, which is similar to 10, maybe as much as 12 milligrams of oral morphine, and the same of hydrocodone. Oxycodone, it's about 7.5 milligrams. And this is a helpful helpful conversion that you can look at. Morphine 1 milligram IV is the same as fentanyl 25 micrograms IV, which is the same as 0.25 milligrams of hydromorphone. I'll say that again. Morphine 1 milligram IV, same as 25 mics of fentanyl, same as 0.25 milligrams of hydromorphone IV. Okay, are there any questions so far? I'll bring up the chat so I can keep an eye just in case. Okay, so the fentanyl patch, let's talk about that. It's transdermal, so it's absorbed, but what does it absorb into? It's absorbed into adipose tissue, fatty tissue. So if somebody doesn't have much fatty tissue, they're not going to absorb the medication that well. It over the course of 24 hours, it gets absorbed into this fatty reservoir, and then it extends out to the body. But you can begin to see an effect starting at about 6 hours. So if you put the patch on, you're not going to see an effect right away. It'll take at least 6 hours. Generally, the full effect is seen by 48 hours. So it's important to educate patients that they can't just slap a patch on and expect to be pain-free in an hour. It takes a lot longer than that. Or if they're in the ICU and the ICU team is wanting to start a patch and stop the drip and send them out of the ICU to the medical floor, they're going to have a gap in coverage if they just stop the IV drip. So we would avoid the fentanyl patch if they're cachectic because there's not enough adipose tissue to absorb the medication. The patch size, the easy way is calculate your 24-hour MME dose, morphine milligram equivalents, and divide by 3, and then usually round down to the nearest 12 microgram increment, and then dose it every 72 hours. It's also helpful to know, as we mentioned, 1 milligram of morphine is the same as 25 micrograms of fentanyl. So if they're on a morphine drip, 1 milligram per hour, that's the same as a 25 microgram per hour IV fentanyl drip, or the same thing as a 25 microgram fentanyl patch. Don't increase the patch more often than every 48 to 72 hours. I would recommend 72 hours just in case there's full effectiveness by then. And there are other forms available besides transdermal. There's IV, oral, buccal, intranasal. And basically 100 micrograms of oral fentanyl is the same as 1 milligram of IV morphine. Okay, now let's turn our attention toward refractory pain. This is a man with stage 4 esophageal cancer who has a PEG tube because he's had an esophagectomy. He has debility. He has had a 20-pound weight loss within the last few months. He's cachectic. He has worsening pain control despite escalating the fentanyl patch, which is now at 200 micrograms. Gradually over the past 3 months, he's asking for pain medications every 2 to 4 hours, and he's on PRN Roxanol, like 20 milligrams, in order to control his pain. So he's admitted with intractable pain, dyspnea, and anxiety. He looks very uncomfortable. His respiratory rate is 30. Ironically, his lungs are clear. His albumin is 2.0 and his BMI is 17. So why is his pain out of control and how can we help? All right, so fellows, chime in. What do you think?
Transdermal's not working.
He's cachectic, he doesn't have any fat, and
Yep.
therefore the transdermal isn't working.
Right. That is exactly right. So taking a step back, if somebody's on a lot of opioids and they're in worsening pain, uncontrolled pain, what is your differential diagnosis? What do you need to think about? Now, is there something new going on? Is it infection, inflammation, ischemia? Is it disease progression like cancer, metastatic disease? Is it poor opioid absorption through the gut or the skin? Maybe they have an ileus or gastroparesis, or again, the cachexia issue. Maybe there's abnormal metabolism, but again, that would be more of a chronic issue. Pain type might not be as responsive to opioids. For instance, neuropathic pain tends to be less opioid responsive and more responsive to other modalities like gabapentinoids or TCAs or SNRIs. Emotional, psychological, and spiritual pain. Always keep this in your differential when somebody's having worsening pain. Are they developing tolerance or withdrawal or hyperalgesia? Or pseudo addiction versus opioid use disorder. Joel touched on this last week. Pseudo addiction meaning pain is uncontrolled because they're inadequately dosed versus opioid use disorder, which is where the mu receptors are being upregulated and it's like pouring fuel on the fire. Giving more opioids gives basically more demand for opioids later. All right, so let's talk about managing refractory pain. Once you determine the pain is moderate to severe and that opioids are appropriate, you can either add or increase the opioids. You can increase to a more potent opioid. You can change the route of administration, oral to IV, for instance, or if they're not absorbing it through the skin, then get changed to IV. And then you can use a PCA pump or a continuous IV infusion. There's a separate lecture this year that talks about IV infusions of opioids. And then there's the option of using an NMDA blocker if they're having severe chronic or neuropathic pain, such as methadone or ketamine. And again, there are separate lectures this year that address these. So IV opioid infusions, this is for ongoing severe pain or shortness of breath, despite IV boluses that are needed at least every 2 to 4 hours. It results in better pain control more consistently. It's actually safer and better tolerated because the dose is spread out. You get less sedation and less hypotension, and ultimately greater patient satisfaction. But the important thing to remember is that the IV boluses will get them comfortable. The drip will maintain control, but it won't get them comfortable right away because it takes an hour or two for that first dose to get in their system. So get them comfortable with a bolus, maintain comfort with a drip if needed, if this is going to be ongoing and severe symptoms that need continuous medication. All right, so we ended up starting a morphine drip on this gentleman, ultimately 6 milligrams an hour based on opioid conversions, and I worked closely with the pharmacist. So now we have to figure out how do we get him converted to an oral regimen. He's comfortable, he's alert, he's talking, he's completely, he looks quite comfortable. So what long-acting opioid should we use? noting that fentanyl patch is not being absorbed because he's cachectic, and that long-acting opioids cannot be crushed to put through a peg tube. If you crush them, they become immediate release. So MS-Contin, OxyContin, for instance, can't be crushed. So what do we do? What's another option? Fellows, any takers?
Lingual?
Methadone?
I heard someone say methadone. Very good. Okay, so methadone is actually very good for chronic refractory pain. It's a mu agonist and an NMDA antagonist. And then we have a separate lecture on this by Dr. Emery later in the year. And it's so I'm not going to say a whole lot, but just to give you some introductory information. Methadone really is only FDA approved for chronic pain in opioid tolerant patients. And it's helpful. Its niche is neuropathic pain and also hyperalgesia. The advantage is it's potent, it's inexpensive, it's been around for decades, it's generic, it's well tolerated, it can be given in a number of formats, and it's the only intrinsically long-acting opioid that can be crushed or given as a liquid. There's a liquid form that's 10 milligrams per ml. It's called the Intensol solution, and you can give that sublingually or orally, and it stays long-acting because that is intrinsic to its chemical composition. You can have onset of effect within an hour, but most of its effect is long-acting. The duration of an individual dose could be as much as 12 hours. It's hepatically metabolized. It's very long-acting, and its elimination half-life is in the order of 3 to 5 days or longer. Starting dose in the elderly could be as low as 2.5 milligrams, or possibly even 1 milligram if they're only needing a very small amount, or they're frail elderly. Typically dosed every 8 to 12 hours, or perhaps just daily in the elderly. And for dose conversions, it's not linear. It's more of a curve. So if they're on 60 MME or less, then the conversion ratio is 5 to 1. So divide 60 by 5, that equals 12. And then you can reduce that for incomplete cross tolerance. That's your total daily dose. So if you're dosing it 2 or 3 times a day, you're going to divide that number by 2 to 3 to get your dosing. If they're on 60 to 200 MME, then divide by 10 to get your daily oral methadone dose. And then if they're on 2 or more than 200 MME, then divide by 20. And that way you don't overshoot and end up causing them to be oversedated or even develop respiratory depression and perhaps even death. So start low, give it time, give it 3 to 5 days to kick in totally before you make any dose changes. And make sure you've got PRN opioids available for the breakthrough pain. So in this gentleman, so we calculated his 24-hour MME. He's on 6 milligrams per hour of morphine, 6 times 24 times 2.5 to get the IV to oral conversion equals 360 milligrams of oral MME. So then you divide, because that's over 200 milligrams, you're going to divide that by 20, which equals 18 milligrams. And if you want to be on the safe side, dividing it further because of the incomplete cross tolerance, you divide the 18, you knock it down by at least 25%, and you get 12 to 15 milligrams per day. And then if you dose it 3 times a day, divide that number by 3, and you get 4 to 5 milligrams TID. So he's opioid tolerant. So if we did 5 milligrams TID, you can give it as a 5 milligram tablet. You can split the tablet in half to 2.5 if you need to do that, or use the elixir. And that will give you an appropriate equivalent dose of methadone. Obviously, hold the dose if they're developing respiratory depression or if they're too sleepy, too lethargic. But I would caution you that oftentimes when people who've had refractory pain finally get pain relief, they often sleep for many hours because they're finally able to rest. The key is, can you wake them up? If you can wake them up and have a conversation with them, then they are not over-medicated. But if you can't wake them up and they're really lethargic, then the dose is probably too high. Some pitfalls or cautions with methadone: don't rapidly escalate the doses because they can get respiratory depression, over sedation, cardiac arrhythmias like torsades, VT, VF. or even die. So you titrate slowly. Outpatient, every 5 to 7 days. Inpatient, you could probably get away with every 3 to 5 days, but only if they're in a monitored setting. And then use with caution with concurrent sedatives such as benzodiazepines or alcohol. And grapefruit juice affects metabolism, and it prolongs the effectiveness of the medication. Also, meds that increase the QT interval are a risk. So because methadone can increase that, you want to avoid or stop the methadone if the corrected QT is greater than 500 milliseconds. So some of the drugs to keep in mind, there's certain antibiotics, antipsychotics, antiarrhythmics, cardiac meds, cisapride, conivaptan, some of the antifungals, antiretrovirals, and some of the targeted immunotherapies. Now, when you're monitoring patients on opioids, it's helpful to monitor for two basic things. Number one, therapeutic effect. Is the drug working? And number two, are there any adverse effects or toxicities or side effects? So subjectively, you can ask them, how's their pain doing? What are they able to do? What's their function? What's their quality of life? Objectively, you can look at how much of the time are they able to walk, or how far can they walk? Are they sleeping better at night? Are they able to work? How much of the rescue opioid dose have they been using for breakthrough pain? For adverse effects, some of these may be surprising that maybe you weren't aware of. I mean, everybody knows about constipation or nausea or vomiting. I mean, the constipation is almost universal with opioids. And they know about sedation, but things like dizziness, itching, particularly with morphine, which is more of it's a direct mast cell release, not an immune mechanism. So technically it's not an allergy. It's more of a sensitivity or side effect. Hallucinations, dry mouth, urinary retention. This is important, especially in the hospitalized patients. Sweating, rash or hives. And then some of the other things you can watch for would be how awake, alert are they versus how sedated, how spaced out they look, how foggy they are. What's their respiratory rate at rest, including pattern and depth. If they're Shane stoking, if they're breathing shallowly, if they're breathing more, down to 8 to 10 per minute, then you don't have a whole lot of margin before they might develop respiratory depression that could become life-threatening. Or do they have pinpoint pupils? Also, monitoring their bowel movements. If they're on opioids, you should always be asking, when was your last bowel movement? And making sure that they're not getting too constipated, and making sure they've got preventive laxatives. Have they been vomiting? How many hours have they spent sleeping? Are there any excoriations on the skin indicating that they've had some itching? And then, of course, the confusion issue. All right. So it's July, it's hot and humid out. A man comes and was brought to the hospital, intubated because he'd been at home. He has COPD and is on chronic long-acting morphine for pain. He became somnolent after being outside all day. Respiratory rate 6, that's 87%, myoclonus. Another case of a woman with chronic cancer pain was given 4 milligrams of IV morphine for severe breakthrough pain. And 15 minutes later, the nurse calls you and tells you that she's really sleepy. She's breathing 8 times a minute and her SATs are 91%. So what should you do? This issue, and you may see this on the boards, the issue of, do you give naloxone or Narcan or not? And if so, what dose do you give that will help preserve pain control while reversing respiratory depression? So, so for the first case, is this life-threatening? Yes. Are we going to give naloxone? Yes. What dose do we give? 0.4 or 0.04?
04.
Yeah. Good answer. 0.04, 1/10 the normal dose. For the second case, her SATs are still above 90. She's breathing 8 or more times a minute. She is arousable. So you can simply provide oxygen, monitor her, and wait for the opioid side effects to wear off. And in the future, don't give her 4 milligrams. start with 1 or 2 milligrams and see if that's enough. All
I
right,
do
so
have
this is what we call a near miss. This is something that you,
Mike, we got
Yes?
another question here a second.
So why a lower dose?
Of
You guys
Narcan.
knew
Withdrawal.
all around away, but yeah.
They'll get real feisty with the 0.4.
Like
yeah,
just overshoot and they get.
Oh, yeah.
You can
yeah, I
titrate.
will,
Yeah.
I'll get into that.
Hard to bring
Um,
back that
Okay.
Yeah.
microgram.
Sorry. All right. My bad.
So, yeah,
Okay.
so opioids, obviously respiratory depression is the most feared side effect. And it's more likely in people who have underlying COPD, heart failure, obstructive sleep apnea, if they're CO2 retainers, or if they have an upper respiratory illness. Often also in organ failures that may prolong the clearance of opioids, sedative use, advanced age, opioid naive, or rapid dose increases. And so the first thing you do is assess, is it life-threatening or not? And if it is, I mean, obviously you're going to hold the opioids temporarily, remind the patient to breathe if they're able to be awake. But if they're not and it's life-threatening, you give basically 10 to 25% of the normal dose, because this is enough to reverse the respiratory depression, but not enough to make them go into opioid withdrawal or terrible refractory pain that you can't do a thing about. I learned my lesson the hard way before I became a palliative medicine physician. I was a hospitalist and I gave somebody Narcan, and she woke up screaming in agony and in immediate withdrawal. And because I had just blocked her opioid receptors, there wasn't anything I could do to relieve those symptoms. It woke her up all right, but had I known at this time, and actually this is something I've never had any medical students or residents say, oh, they teach us that in residency. I already knew that. Nobody has heard this before our palliative rotation. So spread the word among the residents. Give 10 to 25% of the dose initially, which should be enough to reverse respiratory depression without making them in terrible pain or opioid withdrawal. And if you need to repeat the dose, you can do so. Maybe even start a drip if it's that severe. But just keep that in mind. Okay, here we have a man with an ischemic leg and gangrene who required amputation. He complained of such severe pain that the attending escalated his opioids rapidly. First, he got 0.5 milligrams of hydromorphone, then 1, then 2, over a 6-hour period. Initially, it helped, and his PRN doses were every 2 to 4 hours after that. On post-op day 2, he was sleepy but arousable, irritable, and complained of severe pain all over with minimal touching. Further IV opioids don't seem to help relieve his pain and just make him more somnolent. What's your diagnosis?
Full pain.
Opioid-induced hyperalgesia. I'm assuming he's been on more than just the
Sounds like the guy.
24 hours of pain meds. He's probably been on pain meds for a while.
Yeah, but the key here is rapid dose escalations and of the IV meds. But you're absolutely right. Opioid-induced hyperalgesia, which is where they have paradoxical hypersensitivity to painful or even normal stimuli. And it's typically seen where you have escalating opioid doses, and the pain, it's like you give more and the pain just keeps going up and nothing has changed in terms of the underlying pathology. But it's physiologically, it's because of upregulated mu receptors, and it's associated with skin hypersensitivity all over, not just focally. Confusion, sleep disturbance, restlessness, irritability. It can occur within hours to days of opioid initiation or dose increases, and it may last for days. Risk factors, rapid dose increases and high doses. And the treatment is rotating opioids or reducing the dose or using adjunctive medications like NSAIDs or acetaminophen or the neuropathic meds, or using non-opioids. You can also use methadone and ketamine because both of them block the NMDA pathway, which is implicated in this as well, and buprenorphine. Now I'd like to turn our attention toward opioid use near end of life. This is a 92-year-old woman admitted to the hospital with severe abdominal pain and encephalopathy due to bowel perforation from underlying colon cancer. On admission, the patient, who's barely awake, but also the family, is saying they just want her to be comfortable and not suffer. They don't want surgery, they just want comfort care. So IV morphine is ordered, 2 milligrams and 4 milligrams every hour as needed. 5 minutes after receiving the 4 milligram dose, the patient dies. And the nurse is upset because the family now says that she killed the patient with morphine. They wanted her comfortable, but they didn't want to hasten her death. And I guarantee you, you'll see a question about this on the boards. The question is, do medications like opioids hasten death? And the answer is no, not when you use appropriate or proportional doses based on the symptoms. And this ethical principle of double effect, basically the idea is a medication like morphine can have good and bad effects. The good effects, obviously, pain relief, relief of suffering. The bad effect, respiratory depression and/or death if the dose is high enough. So death after opioid administration, if it's dosed proportionally for relief of pain and shortness of breath, is due to the underlying disease, not due to the medication. So families often say, well, I don't want morphine, or I've even heard doctors say, well, we could give morphine, but it might stop his breathing. And so then the family says, oh no, we don't want morphine. We want to be comfortable. We don't want morphine. That's liquid death, isn't it? No. It's not a dichotomy like that. It's not a impossible choice where you either make them comfortable and they die sooner, or you don't make them comfortable and they linger longer but suffer. There is a middle ground, and that middle ground is using proportional sedation or proportional analgesia based on the symptoms. But the intention, and this is the core of the double effect, is what is your intention? If your intention is to relieve suffering and symptoms so someone can be comfortable, that's considered a benign intention. Your intention isn't to kill the patient or hasten their death. So ethically, it's appropriate to give opioids at end of life. And this is a battle that was fought probably, this article that I originally quoted was from the year 2000. That's when people did have a lot more anxiety about giving opioids because of the fear that it could hasten death. My experience over and over has been that when patients get more comfortable, they actually do better and live longer than when they're suffering. Their color improves, their blood pressure improves, they relax, their heart is less stressed, they're breathing more comfortably so they don't get all tired out. So it actually can help them live longer and more comfortably for the time they have. So to me, it's a win-win. And we have an ethical duty to provide comfort at end of life. So, but near end of life, opioids are metabolized differently as organ failures develop. So generally, you may need to reduce the dose or use longer dosing intervals as they get dehydrated or have lower oral intake, low albumin, develop renal or hepatic failure or fever. If they're oliguric or anuric, then use mainly PRN, short-acting medications. And in particular, avoid codeine or tramadol if someone's GFR is less than 30. Avoid long-acting morphine or oxycodone. Alternatives to morphine would be fentanyl, that's preferred in renal failure. Also methadone, buprenorphine, hydrocodone, hydromorphone. But again, you're probably going to need lower doses because the body's not going to clear it as fast. And you can also change the route. So if they develop severe cachexia, then obviously change to oral or IV instead of transdermal. If they have dysphagia, then you have to determine, do you need to use sublingual liquids like morphine or Roxanol, or use patches if they have enough adipose tissue. Oral, sublingual, or rectal are all considered enteral routes. IV or sub-Q, so if they lose their IV access, you don't have to give it IM. That's painful. You can give it sub-Q. And then, of course, the transdermal option. So in summary, we've discussed how to assess pain through an individualized person-centered approach including patients with impaired communication. Talked about the pain AD score, identifying non-opioid and opioid-based approaches to pain management, including opioid dose conversions in palliative care patients and dose reductions with organ failures near end of life, and identified common options for treating refractory pain. And we'll have some lectures later in the year that'll cover opioid drips, methadone, ketamine, buprenorphine. Those are excellent lectures, and I encourage you to stay tuned for those. So with that, I will turn on the video and stop sharing my slides. And I'll send a copy of the slides to Susan. Just a minute. Okay. So are there any questions?
I had a couple of questions. With the sublingual dosing of medication, you said that's essentially enteral, but
Yes,
is the absorption and onset for sublingual not faster because it's like
it is
vascular?
faster.
Okay, so you can't like treat it in equal. So do you usually cut back your sublingual doses compared to like an oral?
Not necessarily. It just means
Okay.
that the dose will kick in a little faster. A, because it's already a liquid.
Yeah.
B, because of the submucosal absorption as opposed to the gastric absorption.
Right.
So, for instance, that's why sublingual morphine is used so frequently in hospice, because it can be given to somebody who can't swallow pills because it gets absorbed sublingually. It can get absorbed if it trickles down into their lungs, it gets absorbed that way, or it can trickle down into their stomach and get absorbed that way. And it typically kicks in within 15 minutes, as opposed to a pill, which is usually going to take at least 20 or 30 minutes, probably 30 to 45 realistically, before a pill kicks in, because the pill's got to dissolve and then it's got to get absorbed and then go through the liver.
Yeah,
So,
right. And then is anyone actually using codeine in palliative? Please tell me no.
I haven't seen that in a long time.
Okay, because like it's like equal to Tylenol with
Except
the
in cough
added
syrup.
benefit of like vomiting. That's like the head-to-head. So it's like
Yeah,
like
codeine
no
is
gain.
codeine causes terrible constipation and nausea.
Okay, I just saw it on there and I was like, and then at the
Yeah.
beginning, at the very beginning of the lecture, just so things are right, you guys have an alpha antagonist listed, and I think for alpha twos, and
Yes.
it should be an agonist. So it's just on the slide as antagonist.
Oh,
It should be an alpha, right?
so what
No,
I
I
was,
just like, getting the language right early.
Yeah.
Yeah, it's an easy mistake, like, because
Yeah.
you think, so it's
Yeah, so things like,
it's an agonist, so.
so clonidine and dexmedetomidine or Precedex are examples there.
Yeah.
It's not often used that way, but those medications can be helpful in refractory situations. But yeah, thank you.
So it's an agonist.
Correct. So it's listed as a blocker on there,
Okay.
and I'm just like,
Okay,
That's
I
not-
want to go
Yeah.
back to codeine as well. Do you guys know the mechanism how codeine works?
it's,
Prodrug, I guess.
yeah, prodrug.
Gets converted into morphine.
And yep, so it's a prodrug, gets converted to morphine. Key there too is genetics.
Yeah,
Some people have the enzyme, other people don't have that enzyme. So some people, they won't even convert it to morphine. So for them, it's going to be an ineffective drug all around. So you'll have some non-metabolizers, but you'll also have hypermetabolizers who will metabolize it very quickly and get a larger dose than you're anticipating.
I think the vast majority of the population does not have the enzyme then. You know what I mean? Like, because it's just like.
in the emergency
like-
room, nobody has the enzyme.
Well, but codeine specifically has been used so long for children and elderly, thinking it was like safer than morphine. And you're just making them miserable and not providing any real relief, so. It's like cilantro, right? Mint, it's either tastes good or it tastes like soap. Love or hate.
Other questions for Dr. Trexler? Well, thank you again, Mike. I always
Yeah.
appreciate this lecture, and love all the conversion tables. It's.
And I'm super sad that Borges is now Beacon, because I used to work there and that just seems like wrong.
Yeah, well, we're hoping that it'll be a good thing. So we're just, we're
Sounded sad.
rolling with the punches, and they seem more, they're a local, they're out of northern Indiana, so we're hopeful that they will, as a local entity, will pour a lot of attention to help us maintain and grow what we're doing here in Kalamazoo. So I did want to also mention that these opioid conversions get easier the more you do them. So even though initially it may seem daunting, it actually does get fairly straightforward once you get the hang of it and use it a lot. The board exams have the table on the exam, so you don't need to memorize the table. But on the other hand, the more you use it, the more you just know what the conversions are. So I don't even look at the table anymore because I've used it so many years that it's just second nature. But for residents and fellows, yeah, use the table, can become comfortable with the different conversions between the IV to oral and different opioids to each other, and it will get easier. And ask your pharmacist or ask your faculty. We're happy to help and happy to make this a lot easier for you.
Well, thanks again, Mike. Thank you.
Thank you.
Thank you.
Thank you.